Hello, my name is Dr. Dewan S. Raja. Today I will discuss about the histopathology and the pathogenesis of celiac disease. Celiac disease is an immune-mediated gluten-sensitive enteropathy. It is triggered by ingestion of gluten-containing food like wheat, rye, or barley. It is characterized by diarrhea and malabsorption, also called gluten-sensitive enteropathy, also called celiac sprue or non-tropical sprue. It is more common among the white population. It is equally distributed among the male and female, and it may be manifested in the early age, at the age of 6 months, maybe at the age of 30. Its presentation may be variable from person to person. The primary treatment is gluten-free diet. So if the person don't take the gluten in the diet, then he will not suffer from celiac disease. And there is some also genetic background for celiac disease. It may run in some families. Okay. What are the physical findings of celiac disease? Weight loss, diarrhea, failure to thrive, abdominal pain, will get abdominal pain in the patient, nausea, vomiting, anemia. Anemia may be iron deficiency anemia. Anemia may be megaloblastic anemia, may be due to folic acid deficiency or vitamin B12 deficiency. Osteoporosis, because there is lack of calcium in the body and calcium metabolism is altered. Angular stomatitis, inflammation at the angle of the mouth, and aphthous ulcer. These are the physical findings of the celiac disease. Laboratory test and diagnosis, complete blood count will get the pictures of anemia and hemoglobin level may be low. The RBC may be microcytic if in case of iron deficiency anemia. It may be macrocytic in case of folic acid or vitamin B12 deficiency anemia. Serum iron study, folic acid level and calcium level study is very important to diagnose particular type of anemia or, to find out the blood calcium level to assess the bone health. Anti-gliadin and or anti-endomysial antibodies are important factor to diagnose. This is very specific. Anti-endomysial antibodies. We have also anti-gliadin antibodies. HLA-DQ2LL study. Biopsy of the small bowel is the gold standard, and biopsy should be taken from the duodenum or from the jejunum because the first half of the small intestine, the duodenum and jejunum, get most of the gluten and gliadin. Gliadin is the byproduct of gluten. Unequivocal improvement in both symptoms and mucosal histology by avoiding gluten in the diet. So if a person don't take gluten, then his histology will be normalized, symptom will be decreased. In doubt, gluten challenge and rebiopsy is a way to diagnose celiac sprue or gluten enteropathy. We'll go to the histopathology. Now, if we go to the histopathology, then we'll find out in celiac sprue there is diffuse severe atrophy and blunting of villi. These are the villi. This is normal. This part is the biopsy report from a typical patient of celiac sprue. This is normal intestine. We are seeing villi. Villi are lined by simple columnar epithelium with a lot of microvilli forming the brass border. We have the goblet cell here. This is lamina propria that contains blood vessels and lacteal. And these are part of the crypts of liver cone here. Crypts of liver cone. Okay. And we are getting this villi in the intestine, especially it is very much prominent in duodenum. Also, it is seen in jejunum and ileum. So this is normal finding. This is abnormal finding. The villi has been obliterated, has gone, disappeared due to degeneration. But the crypts of liver cone, this is the crypts liver cone. It is now hypertrophied, maybe tortuous, and this is a diagnostic picture in the lamina propria, almost going to the muscle layer, the large crypts of liver cone, but the villi has been lost totally, and infiltration of the chronic inflammatory cell like that of lymphocyte, macrophage, plasma cell, mast cells are here. This is the typical picture of celiac sprue. Okay, so although the villi has been lost from here, villi with microvilli has been lost, but the overall thickness of the mucosa is not lost because we have plenty of lamina propria. There is a loose connective tissue like this with infiltration of the chronic inflammatory cell and very large crypts of liver cone. Okay, so what are the long-term risks of celiac disease or gluten enteropathy or celiac sprue or non-tropical sprue? Same multiple name. Long-term risk, patients remain well with gluten-free diet, they may die from other reasons. So without gluten, a person can survive almost normal. Long-term risks still remain, although gluten-free diet may be decreased but still remain, and there may be chance there is more chance to get intestinal T cell lymphoma and small cell adenocarcinoma of the small intestine that may happen due to celiac sprue or gluten enteropathy or non-tropical sprue. Okay, so we'll to summarize now. This is called the celiac sprue or celiac enteropathy or non-tropical sprue. It happens due to the presence of gluten and some individual cannot tolerate it and they have diarrhea, malabsorption and retarded growth. What happens in the small intestine? The villi are lost, microvilli are lost. There will be prominence of the crypts of liver cone and the and there will be malabsorption, diarrhea, weight loss. There will be infiltration of chronic inflammatory cell like that of lymphocyte, macrophage, plasma cell in the lamina propria of the small intestine, especially the duodenum and the jejunum. So if a person don't take gluten, and then its byproduct is gliadin. If the person don't take gluten, he may survive many years without any problem. But there is more chance to get some type of cancer, that is T cell lymphoma or adenocarcinoma of the small intestine. And that's all for today about the celiac disease. Please support my channel, subscribe me, share the information with your friend. If you have any question, please feel free to ask me. And have a nice day. Bye now.